welcome. Thank you for joining us today on this Wednesday morning or Wednesday afternoon, depending on where you're coming in from. My name is Carrington Lott. I'm the Deputy Director at Systems for Action. And if you're not familiar with Systems for Action, we're a national research program office funded by the Robert Wood Johnson Foundation. Our program office is housed at the Colorado School of Public Health in the Health Systems Management and Policy Department. And one of our large activities that we do at Systems for Action is develop annual funding opportunities and release those, and people respond to them with their unique ideas of how to align across systems. So when we say systems, what we're really referring to is the public health, medical, and social service systems. So today you're going to be joining us to listen to one of our grantees that was funded for a pilot study back in 2022, and their project just recently finished. They were funded to do a pilot study for 12 months, and they were looking at aligning faith leaders and healthy outcomes for children in New Jersey. And their project was titled Faith and Hope for Equitable Systems Alignment. And I know that you can probably see a longer title here on the screen, but I know Dr. Stevens will go into more detail on that. So before we get started, I am doing just a brief welcome, going over some housekeeping items, and then I'll hand it over to Dr. Stevens and Reverend Armstrong, who will tell you more about their project. And then I know that we are lucky to have Pam here, who will be providing some commentary on the research that is being done from this project and the importance of it in the community. And then after that, we will have time for Q&A. So Dr. Stevens, can you please go to the next slide? Thank you so much. So as you can see, we're in the welcome, and then Dr. Stevens and Reverend Armstrong will do the presentation. We'll have commentary, like I just mentioned. If you have any questions at any point during today's presentation, please locate the Q&A box at the bottom of your Zoom screen and enter it in there, and we'll make sure to reserve some time at the end to answer those questions. If we don't have time to answer all of the questions, what we do is typically collect all of the questions that were unanswered and give them to the research teams so that they are addressed at a later time. And last thing I will say is that today's session is being recorded. So we will send out the recording as well as a PDF of today's presentation slides. Okay, I think next slide kicks you off, Dr. Stevens. Yep, with that, I will hand it over to you. Thank you so much for joining, and we look forward to the presentation.
So thank you for having us and for the opportunity to participate in this research process. It was very enlightening, and I think it'll be great to be able to share with everyone today the products from the work that we have done. So I'm Allison Stevens, and I work at the Hope National Resource Center. And again, that's healthy outcomes from positive experiences. And we are affiliated with Tufts University. And so I am joined by Reverend Daryl Armstrong. And so Reverend Armstrong was, he and I are co-principal investigators on this project. So Reverend Armstrong, I will let you introduce yourself.
Yeah, absolutely. Welcome everyone. It has been a pleasure working with Dr. Stevens and our team from Tufts and Trenton here at the Shiloh Baptist Church and our affiliate partners. It's been great being in conversation with RWJ, and excited to be able to share our experiences with you. I have been the pastor of the Shiloh Baptist Church in Trenton, New Jersey for the last 24 years. And I am involved at various levels of denominational ecclesiastical leadership. Incoming president of the New Jersey Coalition of Religious Leaders, which is New Jersey's biggest multi-faith organization in our state. And New Jersey just happens to be the most religiously diverse state in the country. So this was a good incubator location for us to do this kind of work. And I'm also serving on our National Baptist Convention's Congress of Christian Education and Training, which we hope to use as a vehicle to put some of these tools and resources into ecclesiastical arenas. So excited to be with you all today.
I think we can jump right in. We are calling our new congregational home visiting model CREED. that is Congregational Relationships for Early Childhood Equity and Development. And so I'll let Reverend Armstrong kind of give the background on how he, pioneered this concept that brought us here today.
So working with faith leaders in socio psychological settings is nothing new to houses of worship. The concept of parish nursing has laid a foundation on how congregants within congregations can transmit evidence-based research and praxis. And so I served as the former director of the Division of Child Abuse Prevention and Community Partnerships for the state of New Jersey from 2006 to 2009. During that time, we in New Jersey introduced what we believe was the nation's first integrated universal home visiting model. And so trying to get NFP and HFA and PAT, Healthy Families America, parents as teachers, nurse family partnerships, many of these McV funded programs, home visiting models of how do newborn parents get access to resources before, during, and after birth. And so from that model, from that experience in working in state government, I tried to leverage that lessons learned to try to employ what is a naturally occurring opportunity in congregational settings, which is to dedicate or bless children, and that pastors and imams and priests have a natural opportunity and a unique window of opportunity to engage families in early childhood education. And so we sought to transfix, if you would, and transfer what was a general introductory class or two about how and why we're blessing your children from a religious perspective, and really try to infuse it with evidence-based understanding and research from what we know about early childhood development, what we know about attachment, what we know about attunement, what we know about bonding, what we know about the delivery of services to parents during their birth, post-birth, and during their pregnancy, I should say. And we've been able to create something that I called early on congregational home visiting, which was a model of 7 lessons to help families understand the development of their child and understand everything from issues such as safe sleep and shaken baby syndrome, all the way to how to access and navigate medical resources in their community. And so our home visiting model is not to displace or replace the McV funded models such as NFP and HFA and PAT, but is to work alongside of those models. And so what we've been able to do is then fuse congregational home visiting with hope. And Dr. Stevens will talk a little bit more about hope, as how do we train clergy to best do and deliver these services to their families. It makes the baby blessing, baby dedication ritual, baby baptism ritual that much richer. So that's congregational visiting in a model, and we've transformed that into this newer model of early education.
I'm going to put you on the spot a little bit, because I also want to just hear that quote that you have, something along the lines of taking care of the blessing that God has given you. I'm misquoting it, but I just really love that, and how you're able to integrate both of those concepts of the faith aspect of child rearing also with some of these other, more evidence-based techniques.
Absolutely. I mean, one of the Jewish wisdom literature quotes that we often use, that children are a heritage from the Lord, the fruit of the womb is God's reward, from the book of Psalms, the Jewish Psalter. And from that Jewish wisdom, we believe babies are blessings. And so because babies are blessings to us, we then have to figure out how to be a blessing to them.
As Reverend Armstrong said, this is really designed to be a complement to existing ministries. And so we kind of had a few guardrails of how we were going to develop this model, again, designed to be a complement. So as Reverend Armstrong said, in particular with ministries, these are unique opportunities that faith leaders have. And I also want to highlight that from our perspective at the university, one of the things that really attracted us to this project is the fact that faith communities have a very unique standing and faith leaders have a very unique standing. Oftentimes in public health, we tend to think of things as being geographic solely and identifying people by their zip code. But the reality is that most people, if you ask them who they are and about their identity, they're going to refer to a lot of other things, one of which is probably going to be, if they are religious, their faith community and affiliation in that way. And so when you think about it, faith leaders cover multiple generations. They're working with the grandparent all the way down to the new baby. There are children's ministries. And then in times of great transition, which could cause stress or other issues with families, a new baby being one of those, but also a loss, people tend to turn to their faith communities. And so we wanted to create something that really sort of honored that structure and the fact that faith leaders are and can be our partners. We're going towards the same goals, and really respecting the fact that that is a unique position and how much more people can identify with that than us simply taking a zip code map and dividing things up and saying, here's where you fit and here's where you fit. So we also wanted to make sure that this could be adapted to any religion. And of course, we're including various trainings and tools. So those are the things that we're going to go over. But Reverend Armstrong, if you could tell us about this picture really quickly, I would really appreciate that.
Yep. So this is a wonderful picture of a very dear person, the late Roberta Jane Hawkins, who I met over 50 years ago. She was one of my first social workers. And so my family and I were involved in the Los Angeles County child welfare system. When I was 5, my brother was 2. We were removed from mom's custody because of some physical and emotional abuse from her male companion. And through that experiences, many social workers, many placements, Roberta was one of the first. And I always like to say she made a deep impact upon me. She later became a very dear friend as I grew, invited her to my high school graduation, my college graduation, my graduate school graduation, my wedding, the christening of my first child. And this is her at the christening of my second child. Sadly, Roberta just transitioned March of this year. And I had the chance of eulogizing her and sharing with her how much of an angel she was in my life and the life of my family. And so I always reference Roberta as one of those social workers who did strength-based family engagement from the kind of lens we all want to do it and expect it should be done many decades before her time. And those of you who know the late Bernice Weisbord, many believe to be the mother of family support, did similar work in Cabrini Greens, in housing projects in Chicago. Roberta is my Bernice Weisbord in Los Angeles and a very dear friend. And so much of what I do is because of my grandmother, the late Oprah Armstrong, and the late Roberta Hawkins, 90 years old. God bless you, Roberta. And she's still making an impact on children born and yet unborn.
Thank you so much for sharing. And I appreciate you sharing that because I think it also adds the context of, the genuine spirit that we all have with creating this model and wanting to, expand this to new generations and to help children and families. So looking at the model, this is just a visual representation. As you can see, this is the congregational home visiting and anti-racism, which you will see why we include that model. And the outcome here is that we're looking to expand the scope of faith-based ministries to spread knowledge about and access to positive childhood experiences for each of the 4 building blocks of hope, healthy outcomes from positive experiences. And we really are wanting to focus particularly in communities that are experiencing disparities. And Reverend Armstrong is the pastor of a predominantly Black church. And so that was something that we definitely wanted to consider, to take into consideration the cultural and social context that we're doing this in. And we really believe that that's going to apply to a lot of different communities. So first, you'll see that we have the curricula for both clergy and parents. So again, this is designed to be integrated into existing home visiting ministries. This is not a replacement, but we really hope this is like what we call a plug and play, where clergy are able to just bring this right in and integrate and incorporate faith teachings with the curricula that we've developed. There's that focus on positive childhood experiences for these trainings, and they also address advocacy for self, for family, and for community. And Elder McCormick, who's here with us today, doing the commentary at the end, what participated in some of the early disseminations of that parent training where we talked through self, family, and community. The next component is called the Real Impact Survey. And so as you can tell, we are huge fans of acronyms. And so REAL is the Racial Equity and Assessment, goodness gracious, Racial Equity Assessment and Learning. And that is to see what the real impact is. Again, what Carrington spoke about in the beginning was about systems. And so we wanted to make sure that as we're going out and clergy are telling parents and teaching them about these strengths-based approaches and access to positive childhood experiences, that they actually have access, because the fact is that, racism can have impact on that access to positive childhood experience. And so we have this survey that we would be doing. The Hope National Resource Center is available for doing the data analysis. And really what this does is gather insights for addressing those racial disparities when people are trying to access those positive childhood experiences that are so needed. So at the bottom left, you'll see we also have some implementation science, which of course we're academics, so we had to have a theory for this. We use the normalization process theory. Bottom line, basically, we wanted to make sure that the model had some coherence and that it flowed through the training and resources, that we were able to get more participation by engaging the faith communities, that there was some sort of collective action of faith communities and systems leaders, because there's no point in us collecting all that data through the survey and then not doing anything with it to help people access what they need. And then also reflexive monitoring with flexible content. So again, going back to that idea that we want this to be flexible and adaptable to meet the needs of the congregation that the clergy is serving. And finally, on the bottom right, I really thought this was important, and that is some system science guidance. And so what we do here is to help clergy find ways to promote equitable interactions for children and families, identify relevant systems level changes, and work with systems leaders. So I just want everyone to think about a lot of the, in particular, social justice and human rights, even globally, certainly civil rights leaders have been clergy. And so it is really important to recognize that role and the trusted voice and respect that clergy have when it comes to working in communities and also in systems. And so we wanted to give clergy more tools to be able to leverage the information that they gather, that they know from their work with their congregations, to advance some of that systems change.
If I can say here real quickly, Dr. Stevens, we just completed Black Maternal Health Week, for many of you who acknowledged that work. And the reproductive rights movement and national organizations such as Black Mamas Alliance, the disparity and disproportionality of Black women, what that Black women face, particularly in the birthing process, again, all designed to figure out how to engage public health systems, social service systems, and be advocates. And so not only are we transmitting theological and ecclesiastical understanding and knowledge, but the practical aspect of how do you overcome these barriers to access, and really work with medical systems to create equal opportunities. And so I couldn't let Black Maternal Health Week, and some would even extend it to Black Maternal Health Month, pass without, figuring out how to make sure that we keep aligning this work with national movements, particularly around reproductive rights.
Thank you so much, Reverend Armstrong. I'm just going to take a second and expand on that to say that I so appreciate you bringing up that point. One of the things that just happened to me was scrolling through my LinkedIn, I saw a girl that I went to high school with, and we were debutantes together. She's a pharmacist now, and she was on the local news describing her challenges as a woman with a doctorate degree with her second child. And, having such a negative experience and being at a point of having sepsis and going back into the hospital in shock and basically in the process of dying. And the thing that struck me was, as much as I've known her for all these years, we've never talked about it. That was literally the same experience that I had with my second child, where I almost didn't make it. And it just strikes me about how important it is, especially with faith communities, to have this communication and to have people who are there to try to understand how frequently this is happening, how systemic racism is showing up when people are trying to access services, because pretty much every time I bring up that topic with any Black woman I know, they can tell me a horror story. And so this is just another example of how important the work is to be able to leverage that voice and the involvement of faith leaders within their congregations, within their communities, to ensure that we're actually addressing these issues. Because we can talk all day about prenatal care and all of these things, but when you go to seek that, when you go to get the help you need, you're encountering systemic racism, then nothing's really changing.
That's right.
So next, I just want to give you, again, I'm the academics. I'm going to give you sort of that theoretical concept here. So again, we have the faith leader training, ministry framework, the parent leadership and advocacy training, the real impact survey, and the systems change and alignment work group guidance. So I just want to show you, from the theory perspective, we're somewhere a little along here. So we're really looking at more of an integrationist model. So you kind of see that repeated, where we want people to integrate this, right? We want clergy to adapt this, to integrate it into the teachings that they have, and for it to be adaptable to any, religious group.
And just real quick, to go back, Dr. Stevens, what you see in the terminology and nomenclature is adaptable, as Dr. Stevens has said. I want to be clear that, we're citing biblical counseling within the Judeo-Christian context. If I'm talking in a Muslim context, Quranic context, it would be Quranic counseling. And really, the larger frame would just be biblical, religious or spiritual counseling, and then religious or spiritual psycho-emotional issues. So this is a particular frame that's geared towards Judeo-Christian context, but we definitely understand the broad-based application in a multi-faith and interfaith context.
Thank you so much. And so again, for that parent content, so this is actually a 5-part series that the faith leader facilitates, again, integrating. And there's a workbook with activities and a facilitation guide to support clergy to go through that. And one of the things that's emphasized is that goal setting for self, family, and community, and how to advocate for access to positive childhood experiences. So you see here, this is something that we already had, but we did include this as a part of the content. And this is our, SMART AIM worksheet. And this is, walking people through in a worksheet step by step to think about how they can set goals for themselves, their families, and their communities. And also, what they can do, and adding in advocacy as some of those goals. And that happens throughout the training. And then also, I just want to highlight that we did have, and this was very intentional, a consultant on the project who was a formal consultant. Her name is Amber Robinson, and she is one of our Faces of Hope members, and that is family and community experts. And so really wanted to highlight and emphasize the importance of lived experience in this project. And that is how this parent content was developed. And so that's why we're really happy to have Elder McCormick with us, because Amber actually presented this material and got feedback, and that is how this was created. So really quickly, we keep talking about this thing called hope. And so I just wanted to interject really quickly, just a couple of things so you know what we're talking about. So basically, at the end of the day, we know now that children's brains respond to positive experiences. And so it used to be that we thought that a child's brain kind of formed in these early years, and then that's it. And so now we know a lot more. It used to be that we only thought traumatic experiences would last or cause the brain to change. But now we know that the brain basically responds to any experience. And some of the research that's led to this is, first off, strokes. Even when I was a child, which wasn't that long ago, if someone had a stroke, it was kind of believed that there was a little bit of a limit there. And now we know, looking at various imaging, that you can see different parts of the brain being activated and the brain changing as people relearn different abilities, maybe not exactly to the same level, but we do know that there can be change even in, later life. We know that meditation and literacy also changes the brain. And now we see a lot of post-traumatic growth as well that has been demonstrated to cause changes. So that lets us know, and a lot of other research, of course, but this is just an overview really quickly to help you understand what we're talking about. And within HOPE, what we've done is some research. So it's that brain research, and then also the behavioral research that comes together that really talks about the types of positive childhood experiences that can really create the most positive change in brain development. And these actually help the whole family and the community. And so those 4 categories, we call them the 4 building blocks. Those are relationships, environment, engagement, and emotional growth. So when we go back to some of the content for parents, this is what we were actually, teaching. And one of the activities, which was adapted from a asset mapping guide that was created by Luther Snow, we've called this the Count Your Blessings, right? So it's your personal assets. This is a way, as you see, there's relationship blessings. Who are the people you know and care about? Who can you turn to? The engagement blessings, environmental blessings, and emotional growth. So these are all the 4 building blocks of hope. And this is a worksheet where parents can really identify what their strengths are within their family to be able to leverage those strengths in order to access the things that they need for those positive childhood experiences, again, that benefit the whole family, and then even more so the community. And Reverend Armstrong, did you want to add anything to that?
No, I think what you said is fine. I want to have another point to be made in the next slide. So,
Awesome. So this is another sort of worksheet that's included in the parent content, and this is a positive experience planner. I have no idea how Elizabeth got on there, but we will fix that. It's very bizarre. And so the positive experience planner is a way for people to identify, for each of the 4 building blocks: relationships, environment, social and civic engagement, emotional growth, and really just go through, and whether that's a monthly basis or the next however many weeks, they can go through and say, what are some things that I can do, with my family to create these positive childhood experiences. And one of those things could be as simple as taking, my children to the park, or, making a meal together. Any of those things. We're not talking about things that have to be super expensive. But again, there may be some things that you have to access systems to be able to get, right? You can't really make a meal together if you don't have the adequate access to food. So you may need to access some sort of system to be able to do those things. And so this is a way for parents to be able to map out and say, okay, I have a plan here for how I'm going to start doing this with my family. And Reverend Armstrong?
Yeah. And so what I want to share with this particular slide, it goes back to Roberta. As I shared my experiences within the LA County child welfare system, my brother was submerged in a tub of scalding hot water at the age of 2. And so the issue of toxic stress, he could have died as a 2-year-old infant who experienced severe emotional and physical abuse. The abuse that I experienced from my mom's male companion pales in comparison to being submerged at 2 years old. And so the issue of how do we take and replace those traumatic, toxic stress, traumatic experiences with experiences that are going to help rewire and engage the synaptic connections of the brain is something that has long it propelled me in this work. And so when I think about Roberta, my social worker, our social worker, in the midst of my many placements, Roberta again did this, right? She built relationships with my family, but and particularly with me, and the environment that she helped to shape, the social and civic engagement that she helped to navigate, and the emotional growth. I often say that there are 3 things that Roberta did that helped my positive experiences overtake and overwhelm my traumatic and stressful experiences. She gave me a bike and 2 books, and those 2 books were Hans Christian Andersen's collection of poems and Star Wars. This was 1970s when Star Wars came out. And she gave me a bike, and for me, that bike represented independence, and those 2 books represented intellectual learning and growth. And so these 4 building blocks of hope is really how do you instill and infuse what probably started off as a very toxic and traumatic experience, childhood trauma, and help rewire and reshape that into something that is positive for that young person and or that family.
Thank you, Reverend Armstrong, for raising that. And thank you for sharing your personal experience. I think it is important that we also emphasize this is one of the reasons why we thought, we believe at the Hope National Resource Center that the Hope framework really does align with faith communities. And we have a Hope and Faith Communities Toolkit that Reverend Armstrong and I and a couple of other faith leaders put together a few years ago ahead of this project. And one of the things that we emphasize is this idea that it isn't about where you start, right? That change is possible. And that's something that's sort of a recurring theme in various religious beliefs and faith foundations. And so again, when we look at the positive childhood experiences, Reverend Armstrong is exactly right. Every child needs the positive childhood experiences. That is true. We know that this is a developmental need. But sometimes it's believed that in the event of trauma, that somehow outweighs it. And our research really shows that it doesn't, that positive childhood experiences can really mitigate the impact of the trauma or the ACEs, adverse childhood experiences. And so that does really align well with the teachings and what happens in a lot of religious beliefs as far as, again, that ability to change where, you know, having one event or multiple events does not have to define who you are or define your destiny. And that's part of the real message of the Hope framework, that you can still have healthy outcomes from those positive experiences, regardless if you've never had any kind of issue, but you're not precluded from having a healthy life and good mental health as an adult, just because you have had adversity, which we all will experience. Reverend Armstrong, did you want to add anything else before we go to the next slide?
Yeah, and just lastly to say that those positive transference of those positive experiences doesn't always have to come from the immediate family around you, right? That coaches and social workers and teachers, regardless of their race, regardless of their religion, regardless of their region, can infuse those positive experiences into the life of that child. And for me, that is my living example. It wasn't just Roberta, Sunday school teachers at my church, counselors and coaches at my schools. So what I may not have always gotten in a home environment can be given by those in other environments, regardless of race. Roberta's a white woman who never married and was Catholic, and I'm a Black young boy from South Central LA, raised Baptist. Probably as opposite in some respects as you can get. 40-year different, 30-year difference in life, and yet what she infused and others made a tremendous difference, with my positive experiences outweighing the traumatic experiences. So you are Roberta, whoever I'm talking to out there.
Right. Thank you. And so we'll transition now from some of the curricula to looking at the real impact survey a little bit more. And so I just want to give you some highlights of some of the questions that we have. And so just so you know, we did create these basically gathering research. And I do want to highlight here, down here, some of the research that we looked at was also related to medical gaslighting. There are a number of resources and research that's available. And so a lot of people use that term gaslighting now, but basically it's that idea where people in particular, it appears to be women and people of color. You know, you go to the doctor and you say something's wrong and they say, oh no, you're just a first-time mom, or maybe you just don't understand, let me explain it to you, or you're just ignored. And so I just wanted to highlight that those are the kinds of things that we looked at to be able to come up with these final questions. So one of them, we're just giving a few examples, is do service providers watch how you interact with your children? And so I do want to highlight that as we went out to groups of experts, one question that came up was, and it's so clear with this kind of question, is whether this is truly systemic racism or if it's something that's more interpersonal, right? And are we using the right tactics? And so what we came to was that none of these things are in silos, right? That systems are developed typically because of whoever's creating those systems and whatever biases they hold. Likewise, people who do hold those biases can be held accountable through systemic measures. In addition, someone who doesn't have any of these particular biases may just be following things like a mandatory reporting requirement or following some other guidance or not even realizing because there's some implicit bias. And there are a lot of ways that systems play into it. So this was a really important question and really interesting as far as the feedback that we got. And so that was one question. The next one is, are you questioned when you're trying to access resources or treatment? So for example, does the pharmacy ever question your need for medication? And this happens a little less with, children, but certainly when we talk about that access to prenatal and postpartum medication activities, right? Going in, again, if you're taking your baby to the emergency room, whatever those scenarios are, do you ever get questioned as to why are you doing that? Or is there something more going on? Are you drug seeking? Did you abuse your child? And that's why he has a broken arm. So asking some of those kinds of questions, because they are reflective of more systemic problems. And finally, do service providers tell you that your concerns are all in your head? And so again, that kind of goes back to that medical gaslighting that we talked about. So just so you have an idea, we did have a group of experts, as I keep referring to the feedback. We talked about Amber being a part of our Faces of Hope group. And so we did have several of our other Faces of Hope members to review these questions and give their feedback. We also had a couple of researchers, and we are really thankful to the Systems for Action team here today for connecting us with some of those wonderful experts and researchers who gave us feedback, some of whom actually raised some of these questions about where does this really fit on the spectrum, and how do we know if it's systems showing up on a daily basis in someone's life, or if it's more related to that interpersonal bias. And then also we've partnered with Dr. Sebastian Ramos, who is a researcher at Tufts University, and he was working on something similar. So he actually works in maternal and child health, and really he has an NIH grant where he was developing a survey in order to understand experiences of racism to combat the issue that Reverend Armstrong brought up a little while ago. And so we worked with him and brought together 6 doulas who also identify as Black women and who have experienced childbirth. And they also helped us to refine some of the language here. So those were the individuals that we went to. And because you all are here today, I think it would be really helpful also to get your feedback. We want to get as broad of, information and feedback as possible. And so we will have the link to the survey available for everyone. And I think in the evaluation, there's going to be a little, portion where you can give feedback, because we want to understand how this is resonating with people and whether it's really getting to how these big systems issues and policies and all of these things actually show up when someone's trying to access what they need for their child or their family. So each of these experts designated each of the topics that we had in 3 ways. They were essential, important but not essential, and totally unnecessary. And so that's how we gathered all of that data. We also got some qualitative feedback. So you'll be able to see the questions that we have as of today. Dr. Ramos is actually continuing his study right now. So his goes on for a couple more years and is going to be testing this survey with a group of pregnant women who are seeking services at the Tufts Medical Center. And so we will continue to iterate on this, but it is available for use. And of course, things change, in particular, the way that we understand race and racism. You think how things have evolved just in the past few years. So we want to make sure that it's clear this is not set. It is where we have started, and we have done adequate research. We've gotten feedback, but we certainly want to continue to iterate on this so that it really is useful to as many people as possible. And Reverend Armstrong, did you want to add anything to that?
Just to say that a young man in our congregation is a male doula. And so when we think of doulas, we tend to think of the profession of midwifery or doulas. We tend to think of women. And a young man in our congregation, Peter Bullock, who's 28 years old, first-time father, he created something called Hey Black Dad. And he coaches men or the fathers involved in the relationships through the process of how do you reduce stress upon the mother of your child, whether you're married to her or not. And so doulas again, we have a gender perhaps idea in our head, but there are male doulas as well. And to have a Black male doula in his mid to late 20s working in New Jersey says a lot about where we are in our city, in our county, in our state, about trying to advance the needs of women, Black women, and all women as they go, and the fathers of their children as they go through the birthing process. I'm gonna say a little bit more about what's happening in the context of the state of New Jersey, but I just wanted to raise that issue about there are male and female doulas.
Thank you, Reverend Armstrong. And I think that does bring us into the next topic, which is that systems change guidebook. because it is related to what's happening in the particular community where you are. And so this really is, it's a relatively short guidebook, and it gives some really clear tools and resources to help understand systems and systemic racism, and then kind of what to do with that. So as clergy are gaining this information, working with families, hearing about their challenges, this unique understanding that clergy have about their communities, then what to do with it. And so one of the things that we talk about in there is how to create a value proposition for a systems leader. So, the bottom line is that, we think that people will do these things because it's the right thing to do, the kindness of their hearts, and that might be where we are motivated, or where leaders are motivated from their faith perspectives. But there are other competing kinds of motivations. And so understanding how to create that value proposition for the person who is the decision maker is really important. We also have a couple of family experience strategies, and I'm going to show a couple of those in a second. One of them is empathy mapping. We also have persona development and family journey mapping. So this is really for the systems leader to understand what the experience is and to view it from a human perspective so they can relate to it. And it's not just a report with numbers. They can really see how things are moving and how it impacts the everyday people who are actually their customers. And finally, talk a little bit about policy and administrative levels of change. So there's a lot of ways to change a lot of things, and really identifying what the right lever is really important. So I think a lot of people tend to go, I'm going to write my congressman, or let's go to the state legislature. But, it turns out that, whatever issue it is, it could be the, administrator down at the local, child welfare office who can say, oh, well, we didn't realize that's how it was, or we can change a bit of the process. We can change our, phone answering system. There's a lot of things that can be done. And so understanding the administrative levels, or going to a licensing board, those are policy levers. Where do you go to actually affect the change that you're seeking? So we talk a little bit about that. And Reverend Armstrong, before I go into these examples, did you want to add anything?
Yeah, a couple of things that are unique to this family journey mapping is when engaging public health systems and social service systems. I serve both as a police chaplain and as a hospital chaplain on a volunteer basis, in addition to my work as a pastor in a local urban congregation. And in the hospital setting, I served also as a board member of one of our two hospital systems here in Mercer County Capital Health System. And I really learned the value, both as a board member as well as a hospital chaplain, of the Department of Patient Advocacy. And so hospitals must listen to the patients, and patients must also understand that they have power and that they can advocate for themselves. And so not only as a hospital chaplain am I representing the need to ensure that the doctors and the nurses and the medical professionals are providing culturally sensitive care, I also want to empower the clergy of all religious traditions to understand how they can be advocates during the reproductive process, and ensure that they are engaging, whether these are private hospitals, religious-based hospitals, or even the federally qualified health systems, the FQHCs. How do we promote patient advocacy at the grassroots level and really empower families to be their best advocates for themselves?
Thank you. And so I'm going to go through very quickly and just give you a couple of highlights from the persona development and also the empathy mapping, because we want to leave at least a few minutes to be able to hear from Elder McCormick. So really quickly, this is just an example of the persona development. So this is what you're doing it's to create a person who represents the customers, the children and the families. And so these are all the different components that you would include in there. A quote from the individual, a little bit about their background, a bio, behaviors, their goals, and their self-defined needs. The other thing that's really important is understanding that person's strengths and where they are actually already affiliated and seeking services. So as you can see here, Zuri is a member of a faith community. They also do some activities at the local recreation center and so forth. But this really is to represent a typical individual who is seeking services with the system that you are talking to. And you can do 1 to 3 of these, at most 5, but ideally 3 to kind of give a good representation and understand how this particular policy or this particular issue would impact this, example of a person who's seeking services. And finally, empathy mapping, you're also helping systems leaders to relate to that individual. So you're thinking about what that person says, how they feel, what they think, and what they do. So just to give a quick example here, under does, she's not able to make it to all the follow-up appointments for medication management for her son because sometimes she feels overwhelmed, and she's given her children the best education and family experiences for her capability. She thinks that there could be better ways to leverage her support system, including her friends and families and organizations or providers. But for example, you could be talking to a system who, say, doesn't allow certain individuals to accompany someone to an appointment, right? It can only be that individual, or it has to be the spouse. There's all kinds of ways that this can have an impact on your advocacy efforts. And so with that, Elder McCormick, I want to turn it over to you to really talk about whatever you learned about the whole framework and the development of that parent leadership and advocacy training. And I'm going to go off camera and mute myself. And Elder McCormick, if you are speaking, I'm not able to hear you.
Okay, I'm sorry. I was trying to turn my mute button on. Thank you guys for having me today. Future Hope is the discipleship arm of BWPM Ministries. Our vision is to empower single parents to know that God has a plan and a purpose for their lives, and that through prayer and pursuing and practicing the word of God, they can accomplish this. And also, we want them to know that they're not alone. And I think after hearing everything, it was good to hear all your points today, because of it I had forgotten. But our ministry is more on building relationships, not with their families, but also with the faith community. One of the things that I'm noticing with parents that is in a group, they don't have a religious affiliation. And one of the things that I hear, and I'm hearing from you guys, is that relationships are important. So what I learned, even through participating in this group, was building relationships very important. And that's one of the things I've been doing for the last 20 years, building relationships with our parents. And then by building the relationships with our parents, the children are affected. If you have the parents, then you can develop healthy children. And one of the things that we do is we offer a Bible study once a month, and we also have community involvement where we go to other organizations and ask them to come in and teach our parents about child abuse, teach our parents about building budget, part of your program too. What I love most about this program was dealing with the self, dealing with the parent, and dealing with the children, and knowing how to navigate community. That was really, and so I just you involve the faith community program, and it gave us the opportunity to share. Like I said before, some of our they don't go any kind of church or any kind of organization dealing with the church, and we have about 15 parents in our program, and it gave participated the opportunity that they can do more.
Thank you so much for sharing, and I'm so glad that our program was meaningful for you. And I just really appreciate your perspective. So
Thank
with
you.
that, Carrington, oh, you're welcome. Thank you. Carrington, do I turn it back over to you?
Yeah, of course. I think we have a couple minutes for questions, so we can dive into that. But before that, I want to thank all three of you for coming and speaking about the project. And it's a really important one. And I've enjoyed learning alongside with you. And I think all of the passion that you both have for what you're doing comes through beautifully in your research and the way that you talk about it. So thank you. Okay, so we have some questions that have come through. Like I mentioned at the beginning, if we don't have time to ask all of these questions during today's session, we can make sure to give the unanswered questions to the research team so that we can address them later. So I'm going to start off with a question. Auntie Annette had one earlier about supports and mentoring and train-the-trainer connections that could potentially be made. And I'm going to sort of pair that one with one of her other questions that asks, can you speak to resources needed for places of worship to have the capacity to support being more intentional and engaged in work like this? And I think maybe this might be a good space to talk about your other connections and things that are going on. For instance, Reverend, I know you're very connected into some state boards and international boards in the research in the religious community. So maybe you have some good insight for us here.
Just a quick response. What's happening in New Jersey is the First Lady, Tammy Murphy, married to Governor Phil Murphy, really had a heart and passion for maternal health and dealing with the health inequities and disparities therein. She led an effort in New Jersey to create something called the Maternal Infant Health Innovation Center. And that's a multi-million-dollar facility, that physical place that's going to be built here in the state capitol to help communities of color particularly navigate and negotiate the obstacles that they face in the reproductive process, but not only during, before, during, and after. And so that innovation center is only going to be successful as it engages community. And so we in the religious community here in New Jersey, particularly in the state capitol, and particularly based on the research that we've been doing, Dr. Stevens and myself and Dr. Sagi and Tufts Medical Center, have been able to inform this process, the First Lady, and the work that the state is undertaking about the needs that exist. We don't have to make a hard push that there's racism, implicit bias, microaggressions, macroaggressions that go on each and every day. The question is, how do we engage and empower communities to overcome and navigate those micro and macroaggressions? And so we're excited about what is happening with what we call Nurture New Jersey. If you Google Nurture New Jersey here in the state of, in the state capital in the Garden State, up will come the Health Innovation Center and the kind of work that we're doing with paternal and maternal child health. We're excited about that. But at the basic level, I would always advocate 2 or 3 very basic points around building capacity. One is your state or county should have some faith-based engagement entity at some level. And I would encourage you to search that out, both in our area. There's the Office of Faith-Based Initiatives at the state level, and there are county level engagement arms that are public, private, or quasi-governmental. And if they don't exist, I think this is an opportunity for clergy to help your county executive or county commissioners, your city council, understand the role that you want to play as a faith leader in raising and promoting these issues. I would guarantee you that somewhere on council and your county commissioner offices, the issue of maternal and paternal child health is on somebody's agenda, and you want to help connect that. I also want to promote fairly qualified health centers as places of as a resource, not only for the medical attention that they bring and offer, resource that they offer, but also as places of advocacy. The federal government has a mandate to care for the least and the lost among us, and FQHCs are particularly charged with that. And so connecting governmental entities, with faith institutions, and ecclesiastical bodies, such as chaplaincies, whether that's hospital or police, can be great resources to start these conversations.
Oh, and you can always visit positiveexperience.org if, for additional information about hope specifically and other kinds of tools. But thank you, Reverend Armstrong, for the faith-specific information.
Yeah, and I think we can include both of those links or resources in our follow-up email as well, Dr. Stevens and Reverend Armstrong, if you would like for us to. So I think that question brings us to time. So we're at time. I want to thank everyone again for attending and listening to this research team present on everything that they learned in their 1 year that they were looking into this with the Systems for Action Research Grant. As I mentioned, this is an ongoing research in progress webinar series, so we will be back, I think, next week with another research in progress webinar presentation, which we will include more information in our follow-up email so that you could register for that if you'd like. And with that, I think I'll go ahead and close us out. Thank you again, everyone, and I hope you have a great rest of your day.